Now we're going to go into the musculoskeletal system. These are some examples of what you could write in your book. Write whatever you want to. This might be a little too much for you, but the good thing to write is the terminology, anatomy of joints, ligaments, and tendons, and fracture coding steps. We have provided you with a handout of what we suggest you write in this section, as well as pictures from our instructor's book. The key terminology for the musculoskeletal system is the suffix otomy, which means cutting into, ectomy, which means surgical removal or excision, plasty, which means to reconstruct or surgically repair, desis, which means fusion, and arthro, it means joint, and osteo means bone. The reason these are important to remember is because if the doctor did osteotomy, that means he cut into the bone. Another important thing to know when coding in the musculoskeletal system is the difference in proximal and distal. Proximal means further away from the point of attachment, and distal means closest to the point of attachment. And when it's talking about point of attachment, it's talking about each individual bone. Let me give you some examples from a diagram that I made. This is the skeleton. Let's first look at your humerus. Your humerus is one bone and it attaches in two different places, at your shoulder and at your elbow. We learned that distal means further away from the point of attachment. So, meaning the point of attachment to the middle of the body. So, the proximal humerus, I think of proximal as up. So, the proximal humerus is up by the shoulder, and the distal humerus is down by the elbow. The shaft is the middle portion. So with the radius, the closest to the point of attachment would be up here by the elbow. So that would be your proximal up radius and ulna. Your distal radius and ulna would be down here by your wrist. Same thing with your femur bones. Your proximal femur up by your hip, your distal femur down by your knee. Proximal tib fib up by your knee, distal tib fib down by your ankle. I suggest writing these down in your book. We did provide them in the handout of suggested book notes for all students. The sections of the musculoskeletal system are general, head, neck, back and flank, spine, abdomen, shoulder, humerus and elbow, forearm and wrist, hand and fingers, hip, femur, leg and ankle, foot and toes, cast and strapping, and arthroscopy. Let's first talk about arthroplasty procedures. A lot of the codes in the musculoskeletal system are the same, but just on different body parts. So we won't go section by section for a lot of these. An arthroplasty is a surgical procedure to restore the function of a joint. An artificial joint, called a prosthesis, may also be used. When the entire joint is replaced, it's called a total joint replacement. A total knee is 27447, a total hip is 27130, and a total shoulder is 23472. The subsections to all of the sections I previously mentioned are incision, excision, manipulation, introduction and removal, repair, revision and reconstruction, other procedures, fracture and dislocation, amputation, and arthrodesis. The reason this is important is if you're coding a fracture and your index at the beginning of the section, you'll go to the body area, and then you'll go to fracture, and then you'll go to that page to code. Let's talk about the incision subsections for all body areas. Incision and drainage procedures that only go down to subcutaneous or dermis should be coded from the integumentary section that we just went over. I and Ds, which are incision and drainages, that are performed below subcutaneous tissue should be coded in the musculoskeletal system. Some terms to know in the incision section are I&D, which stands for incision and drainage, abscess, which is a collection of pus that has built up within the tissue of the body, bone cortex, which is the outer shell of most bones, the bursa, which is a small sac filled with synovial fluid that cushions adjacent bone structures and reduces friction in joint movement. Arthrotomy is opening a joint. Fasciotomy is fascia is cut to relieve tension or pressure. Tenotomy is the surgical cutting into a tendon to release it. Now let's talk about fracture coding. This is very common in the musculoskeletal system. Generally, bones heal best when immobilized, so treatment often involves casting the broken bone or fracture and may require surgery to set the bone in place. Prior to casting or fixation, the broken bones must be returned into proper position. This is referred to as reduction. Manipulation and reduction can be used interchangeably. That's a good note to make. Closed reduction or manipulation is the manipulation of a fracture without an incision. Open reduction or manipulation refers to the manipulation of a fracture after an incision into the fracture site. When coding fractures, you will need to know what type of reduction was used, as well as which body part was affected. Was it the leg, arm, finger, foot, etc.? And in some instances, you may need the precise location. For instance, does the fracture affect the head or the shaft of the femur, the proximal or the distal of the femur? Percutaneous. In surgery, a percutaneous procedure is any medical procedure where access to inner organs or other tissue is done via a needle puncture of the skin, rather than by using an open approach where inner organs or tissues are exposed. The doctor will use pins and wires in a percutaneous procedure, and they will not open the patient. So that's an important key terms to use or look for when you are coding a percutaneous procedure is pins or wires. Open treatments are called ORIF, open reduction with internal fixation. An open reduction and internal fixation refers to a surgical procedure to fix a severe bone fracture. Open reduction means surgery is needed to realign the bone fracture into a normal position. Internal fixation refers to the screws or plates used to keep the bone fracture stable in order to heal the right way and to help prevent infection. So the key terms you're looking at in ORIF is screws or plates. ORIF with intramedullary implant. If an ORIF is done with an intramedullary implant, it is coded with the code that specifies intramedullary implant. It is important to note that an intramedullary implant uses a nail or a rod. So when you're coding these and you see the word nail or rod, they are doing an intramedullary implant. They will not always say that they are doing intramedullary. So knowing that the nail is going in the middle of the bone, that is a key term so that you know that this procedure is being done. ORIF with a prosthetic replacement. We talked about arthroplasty procedures where the joint is replaced with a prosthetic implant. This can also be done during an ORIF for a severely fractured bone. The doctor uses internal fixation implants such as pins, wires, or screws, just like they would in a regular ORIF. Then he will replace the damaged portion of the bone with an artificial implant. Look in the documentation to see if they used any type of implant or cement. Those are good indicators. You may also see the note talking about implant sizes or a trowel stem. So let's recap. An ORIF is with plates, screws, etc. If it was with a rod or a nail, that's an intramedullary code. Implant, cement, or trowel stems are prosthetic replacements. Closed treatment, you will need to know, was it with manipulation or without manipulation? Percutaneous treatment, you will need to know if wires, pins, and they did not open the patient. So these are the questions you should ask when coding a fracture. What bone was fractured? What part of that bone was fractured? And what type of treatment was performed? It's your turn to practice scenario 1. There is a fracture on the long finger of the proximal phalanx, which is the finger. This fracture is minimally displaced and the doctor decided surgery did not need to be performed. A closed treatment of the phalangeal fracture was performed. A cast was given and the patient was told to follow up with me in 2 weeks. What is the code? Pause this video and get your code. To get to the code, you would need to go to the table of contents at the beginning of the musculoskeletal system. You're then going to go to the body area in red. So in this case, it was the finger. Once you find the finger section, which is hand and fingers, you're going to go look at the fracture and or dislocation, which in my book, this is a 2017 book because it has my notes in it is the reason I'm using it. But in my book, it is page 143. So we're going to go to page 143. On page 143, we're now going to look for the bone. Notice how I usually bracket these in my book. But notice how this is metacarpal, carpometacarpal. We're looking for proximal phalanx. So it's good to go through and highlight those bones or underline the bones so they're easily identifiable. On the next page, we can see, I see the proximal phalanx, proximal or middle phalanx, but this is a percutaneous treatment. We're looking for a closed treatment, and they did not mention manipulating the patient or reducing the fracture. So we need one without manipulation, which is 26720, closed treatment of phalangeal shaft, proximal or middle, finger or thumb, without manipulation each. We only had one finger that was fractured, so our code is 26720. Now I want you to practice on your own. Scenario 2, a patient is involved in an auto accident and suffers an open fracture of the proximal shaft of the femur. The patient is admitted and the orthopedic surgeon evaluates the patient. The patient stabilizes and the surgeon performs an open reduction and internal fixation with an intermedullary rod. Pause this recording and get your answer. Your answer should have been 27506. Open treatment of the femoral shaft fracture with or without external fixation with intermedullary implant. Practice scenario number 3. A patient trips and falls going up the stairs, suffering a displaced fracture of the ulnar shaft. The physician performs an open reduction with a plate and screws to hold the fracture in place while healing. Pause this video and get your answer. Your answer should have been 25545, open treatment of ulnar shaft, which includes internal fixation. Practice scenario number 4. A patient presents to the emergency department with a fractured metacarpal. After examining the patient and reviewing x-rays, the ED physician asks the orthopedic surgeon on call to evaluate and treat the patient. She confirms the injury and performs a closed reduction. What should we code for the orthopedic surgeon? Pause this video and get your answer. Your answer should have been 26605. Closed treatment of metacarpal with manipulation each bone because they reduced the fracture. Now let's look at injection codes. Injections are in the general section. Joint injections are coded by the size of the joint and whether ultrasound was used or not. Let's start by looking at code 20600. 20600 is an arthrocentesis, aspiration, or injection, small joint or bursa. Your small joints are your fingers and your toes. 20600 is without ultrasound guidance. 20604 is for the small joint but with ultrasound guidance. 20605 is for an intermediate joint, which is your wrist, your AC joint in your shoulder, your elbow, your ankle, or your old cranium bursa, which is 20605 without ultrasound. 20606 is with ultrasound. 20610 is for a large joint, which is your shoulder, hip, and knee, and your subacromial bursa. 20610 is without ultrasound, and 20611 is with ultrasound. 20612 is the aspiration or injection of a ganglion cyst. Some injection codes I really want you to look at are on the previous page on 20552 and 20553. These are trigger point injections. Trigger point injections are injections into your muscle. You commonly get them when you're having muscle spasms. 20552 is coded based on the number of muscles injected, not the number of times the patient was injected. The patient could be injected 5 times, but if it was only into two muscles, you will only code 20552 one time because it says one or two muscles, not per injection. 20553 would be if 3 or more muscles were injected. So if 4 muscles were injected, you're still only coding 20553 one time. And I put a note in my book, never coded more than once next to these codes. Next in the application section is the application of an external fixation system. When you're coding an external fixation system, you need to know, are they applying the external fixation system, are they removing it, or are they fixing it? If they are applying it, you need to know if it was multiplane or uniplane. A uniplane is an example right here. Uni means one. So uniplane is when they're doing it on one side. Multiplane is when both sides are done. 20692 is the application of a multiplane unilateral external fixation system. Removal of the external fixation system is coded with 20694. Next, go to the graft section and the general section by looking in your table of contents at the beginning of the section and going to graft. Codes for grafts may only be coded separately when the graft is taken from a separate incision and when the description of the code for the main procedure does not specify a graft was used. Example, if the main procedure code descriptor says includes obtaining graft, these codes cannot be reported separately. Coding is based on type of graft. You will see in these codes it specifies bone graft, tendon graft, tissue graft, etc. Look at code range 20900 through 20938. There are add-on codes for the spine, and we're going to go over that a little bit later when we're talking about spine procedures. Let's talk about excision of tumors. Each section has an excision of a tumor code under the excision section. Example, let's look at shoulder excision. Codes are based on the depth, was it subcutaneous or subfascial? And they're coded based on size. Turn to the humerus or elbow section and let's look at code range 24075 through 24076. 24075 is an excision of a tumor or mass, soft tissue of the upper elbow area, subcutaneous, which is that fat layer underneath your skin, less than 3 centimeters. Indented underneath it is 24071 for 3 centimeters or greater. If it was intramuscular or subfascial, you would code 24076 for less than 5 centimeters and 24073 for greater than 5 centimeters. Now it's your turn to try. The patient had a 3 centimeter mass excised from the shoulder. The tumor was resected out of the muscle. Go to the table of contents at the beginning of the musculoskeletal section, go to your shoulder section, and then go to the excision section. The correct code is 23076 because this was resected out of the muscle, which is intramuscular or subfascial, and it was less than 5 centimeters.